The topic of this session is about the robotic thymectomy. I am Changhyun Kang from Seoul National University Hospital. I appreciated to the Shanghai Chest Hospital for the invitation to this conference. Today, I'll talk about the current status of robotic thymectomy in the first half of my presentation, and I will talk about the controversial issue in the rest half of this presentation. In history, the first thymectomy was reported in 1911, and the first patient was a 19-year-old girl who had myasthenia gravis and goiter. And as you can expect, the first thymectomy was a transcervical thymectomy because transcervical approach was a safer way at that time. After the first report of the thymectomy, the thymectomy become and more popular as a treatment of myasthenia gravis and thymic tumors. Around the 1930s, and cervical thymectomy and the transsternal thymectomy had been established as a popular method of thymectomy. However, around the 1990s, minimal invasive thymectomy has been reported. The first one was thoracoscopic thymectomy, VATS thymectomy. And robotic thymectomy, today's topic, was reported in early 2000s. And already it passed 20 years. And currently, there are many modifications of minimal invasive thymectomy. Subxiphoid approach or uniportal approach thymectomy is very commonly performed in the worldwide. And when we talk about the advantages of robotic technology, we usually think the basic advantages. For example, three-dimensional vision, and then free articulation, and the maximum magnification. It's the very well-known advantages of robotic technology. However, after gaining some experience of the robotic surgery, we can realize that several additional advantages can be emphasized in the robotic surgery. The first one is that we can make a port anywhere we want to. So the position of a port usually are not influenced by the limitation of the range of arms of a human body, which means, and if we make a port, a very long range of port over the chest wall, and the surgeon's arm cannot control all of the port, but usually robot does not influenced by the location of the port. And when we make a very long distant port, and another port should be controlled by the assisted surgeon. So very special, sometimes very specialized experienced surgeon is necessary. However, in robot surgery, usually it is not necessary. So the complete true solo surgery is possible. The other advantages of a robotic system is robotic arm movement is not influenced by the gravity. So in a very unusual angle, in an unusual location, we can do the operation like as a normal location. And for example, 90-degree clockwise rotation of the camera, we can operate it the higher process like as the decubitus position. Sometimes we can do a upside down position and do some of a complex operation in the chest wall. All of the complex operation can be done by robotic. The other advantage is we can operate it even in very small space. And this is very important, especially in huge size thymic tumor. In case of a huge size thymic tumor, we can get only small space. So in the inside of the small space, we can put the robotic arms, and we can do very fine and meticulous dissection in such a small space. In those pictures, I think this is very important in the thymic tumors, especially in the advanced thymic tumors. So eventually, according to these advantages, I think the robot is a specialized complex operation in thymic tumors. And currently, I think robot surgery is not popular worldwide. However, if you see the trend in the United States, we can expect some of the future trend. And this is a database data from the STS database. And in 2009, only 6.4% of patients received robot thymectomy in United States. However, the number increased to the 44% in 2019. And I think that already in United States, robotic thymectomy is the most common type of the operation. And this trend can be applied in other countries. And in the near future, robot thymectomy have a potential to be the major operation type, all over the world, I think. Like as a VATS thymectomy, robot thymectomy does not mean a single type of operation. There are many different modifications in robotic thymectomy. Currently, in our institute, we are using 4 different types of operations. The first one is a lateral approach. This is the original one that we used in the past. And the other one is a subxiphoid approach. And currently, we are doing the most of the thymectomy using the subxiphoid approach, which we started in 2016. And the other method is the modified subxiphoid approach. We developed this approach, and because sometimes the thymic tumors invaded the hilar structure very deeply, in such cases, more aggressive surgery, including lobectomy, is necessary. And at that time, the simple subxiphoid approach is very difficult to finish such a complex operation. So in such cases, we using this modified subxiphoid approach, we can do the complex hilar procedure. The basic concept of the modified subxiphoid approach is combining lateral approach and subxiphoid approach. And the rest one is the subxiphoid single site approach. And then this the advantage of this procedure is we can make just one port in the subxiphoid area. However, because of limitation of technique and technology, we are now applying this technique in very selected patients. Because of different nature of technical detail and in each surgical procedure, there are several differences between between techniques. And for lateral approach, the most advantageous features are, and it is easy to insert port, and arm handling in the thoracic cavity is very easy, very straightforward operation. However, the most important limitation is surgical view is limited. Just the unilateral approach enables to see the one side of the chest. The subxiphoid approach, then if you port insertion is requires some experience, and arm handling and the first time before gaining the experience is not easy. However, surgical view is very good. And because of the wide view and wide space in the upper mediastinum, more complex procedure is more possible, more suitable in the subxiphoid approach. And for subxiphoid single site, and the most important limitation is the arm handling is very difficult because of the conflict between camera and arms. I think the SP single port surgical system may be better than the single site approach. And then because of the such a limitation of technology, complex operation is nearly impossible. And that's the basic differences of 3 different natures. If you look at the outcomes, already many papers reported the early outcomes of the lateral approach, and they reported good postoperative pain, and low complication rate, and conversion rate was minimal, and long-term survival was favorable. And in subxiphoid approach, the most important the advantage over lateral approach is a low pain. And the postoperative pain level is very, very low. It shows excellent result. And also several papers reported a very low complication rate and a minimal conversion rate. However, long-term survival has not been reported, so we must read more long-term follow-up data. For subxiphoid single-site approach, usually most papers are the case series. We cannot say any conclusive result on the outcome of this approach. And complication rate is unknown, conversion rate is unknown, and long-term survival also unknown. So I think we need more studies to compare the advantages and disadvantages of the three different surgical approaches. This is the summary table for the papers reported on lateral approach until 2016. The first paper is my paper. As you can see in this table, and very similar outcomes have been reported. The included case number was around 10 to 100 cases, and complication rate ranges 1% to 10%, and conversion rate ranges from 0 to 5%. And length of stay also ranges from 1 day to 10 days. As you can see in the table, the early outcomes is quite similar, irrespective of the time or irrespective of the centers where the operation was performed. So in this table, I review the current series of robotic thymectomy published between 2010 and 2011. And the result were different significantly from previous series. Low complication rate and short hospital stay also have been reported in recent series. Among these papers, one was a subxiphoid single-site approach, and the other one is about the subxiphoid robotic approach. As you can see in the result, complication was somewhat higher than the studies of 2010s. I think it is because of the difference of definition of complication. Some centers included all minor complications. However, some centers only reported a major complication. We can check it at comparing length of stay, although the complication rate was different between centers. The length of stay was similar between centers. The next talk will be about the comparison between different surgical techniques, comparison with the open technique and comparison with the VATS technique. And I'll show you the long-term outcomes about myasthenia gravis and long-term survival after surgical treatments of thymic epithelial tumor. When compared with the open thymectomy, it is generally accepted that the robotic thymectomy shows low postoperative pain and a low complication rate and a shorter length of stay. Although not so many studies have been published on this issue, however, usually many surgeons, many experts agree on the superiority of robotic surgery compared to open surgery. And our group reported a comparative study between robot and open thymectomy in 2016. And after propensity score matching, the complication was lower and length of hospital stay was shorter in robotic thymectomy than open thymectomy. However, if we talk about the issue about the comparison between robot and VATS, and there are so many arguments and outcomes of each studies are not uniform. If we should just one advantages of robotic thymectomy compared to VATS, in my opinion, low conversion rate may be a possible advantages of robotic thymectomy. And in this meta-analysis paper, and published recently, and the authors concluded the conversion rate was significantly lower in robotic thymectomy. However, the well-balanced comparative study is necessary. So, in my opinion, a randomized controlled trial may be necessary for this issue. The studies on the long-term outcomes of robotic thymectomy is also uncommon, and especially for the remission rate of myasthenia gravis. This is a paper comparing long-term neurologic outcomes of myasthenia gravis between robot and VATS thymectomy, published in 2011. In this paper, the authors concluded robot thymectomy shows a better complete remission rate with a 35%, 39% complete remission rate after 42 months of follow-up time. I think this is quite a higher complete remission rate. However, recently published meta-analysis shows the different outcomes. And according to this meta-analysis, and the complete remission rate of robot surgery was better until 3 years after operation. However, the difference disappeared after 5 years. It is not easy to interpret this result. So I think the more study on this issue is necessary. The most important issue in robotic thymectomy is long-term survival. However, in this issue, only small numbers of papers have been published. In this PowerPoint file, the left side study comes from Europe and published in European Journal of Cardiothoracic Surgery. They included 53 patients of thymoma and reported 4 cases of recurrence and 2 cases of death. But the authors did not suggest the survival rate in this paper. Second paper comes from United States, and they included 84 patients. However, the authors included very heterogeneous patients, including thymoma, lymphoma, and other malignancy. However, the outcomes was excellent. Only 1 recurrence after median 34 months follow-up. The last paper is ours, and we also reported the long-term outcomes of robotic thymectomy. We included 158 patients, and 132 was a thymoma, and 24 was a thymic carcinoma. And according to our data, 5-year survival was 97% in thymoma and 95% in thymic carcinoma. I think their outcome is comparable to the previous papers for the open thymectomy or thoracoscopic thymectomy. This slide shows annual number of robotic thymectomy in our institute. We started a lateral approach in 2008, and then we started the subxiphoid approach in 2016. And modified the subxiphoid approach in 2018 and subxiphoid single site approach in 2019. As you can see in the graph, the enrollment of the patients was very slow, but recently increasing rapidly. And currently, we are doing the using the subxiphoid approach as a current standard approach in robotic thymectomy. Why subxiphoid approach became a standard approach in our institute? I think there are several factors contributed to this phenomenon. I think 2 patient-oriented factors and 3 surgeon-oriented factors had affected to the outcomes. The green box represents the patient-oriented factors, and the blue boxes represent the surgeon-oriented factors. I already explained about the surgeon-oriented factors, some of the complete thymectomy, visualization, and modification of surgical techniques, something like that. However, I think, in my opinion, the patient factor is more important because of the insurance system of our country. Usually, the selection of surgical methods are determined by the patient himself or herself, not the surgeon. So why patients started to robot surgery more than the other surgical methods? The first one is because of it's less painful. and the subxiphoid approach is definitely less painful than the lateral approach. That's the first reason. The second reason is we can do the minimal invasive surgery even in the patients with very advanced disease, and it's a very striking difference to the thoracoscopic surgery. Some patients in our hospital and come to our outpatient clinic after visiting other hospitals where the open thymectomy was recommended. And in a very complex, very advanced cases, we are doing the robotic thymectomy, very high successful rate and with very low complication rate. That's the second reason why patient choosing the robotic thymectomy. I must conclude my presentation. Robotic thymectomy is becoming a dominant operation in the countries where robotic surgery is popular. And many different types of modification is possible in robotic surgery. However, in my opinion, subxiphoid approach may be a most promising approach. The benefit of robotic surgery over thoracoscopic surgery is unclear in the literature. However, in my personal opinion, I think the advantage is very clear. But however, evidence is very important, so more studies on this issue is necessary. Thank you for your attention.